very rapidly on this. Also, there was quite a bit of building going on in Kempston at the time, because the one thing nobody ever wants to do, if they can possibly help it, is change their doctor. It's very much better the devil you know than the one that you don't. And so you really do have to try and kill the entire family before anybody actually really wants to change their doctor. So mainly you increase your practice by new people coming in and liking the look of your outfit, and by new building, which is in a sense the same thing. Quite a lot of building was going on, and we took an enormous number of people. And of course they were still building in places out in the country as well, so we were taking on people in the countryside. They had branch surgeries as well. The other thing was, people, as I say, expected to die at home as well as be born there. And one realised quite early on that one was going to have to develop a philosophy for looking after the dying. It's an important part of one's job, was looking after people that nobody could do anything more for. The consultant would say, I've done everything, there's nothing more to do, take them away, I'll send them home. That meant it was into my lap. And then, so the idea these days of hospices and that dying is not talked about, and it is now, it occurred to me quite early on that dying was an important part of my job, looking after the dying. Now I was very fortunate in that we had some very good nurses at this time. Because of our equipment and the building that we had space for nursing. And it was decided at the time, when I first came here, the district nurses were territorial. They had an area and they did work there, domiciliary work for all the doctors who had patients they were asked to go and look at. But Miss Frost, who was the nursing supervisor, an absolutely splendid woman, decided that they were going to attach district nurses to exclusive working in individual practices. It ought to work better that way. And as we got the best premises around, this was an ideal place to start. So they sent along, they would like you to have nurse so-and-so. We looked at each other, we thought, no, we're not too keen on that. So I rang out Miss Frost and I said, Miss Frost, we don't really want the nurse you were suggesting. We'd really like Miss Lyons, I said. But Dr. Barber, she said, Miss Lyons, as you know, is the sister in Elizabeth ward in the hospital. Yes, I said, I know, but if you ask her, I think you might find she'd like to come and work with us. Oh, she's right. So the next thing is that Winnie Lyons comes to work with us, and Winnie Lyons was wonderful. This very Irish lady who really cared and was full of lots of old-fashioned remedies and took time with people and was absolutely perfect. And we then, between us, he was also a very devout Catholic. I'm a high Anglican myself, but I mean, it's the same without the Pope and the transubstantiation. It's not a difference really, but I mean, don't tell the vicar that. But it's, you know, we had strong feelings about the dignity of dying, how important it was. And between us, we felt that we would actually try and plan the way we were going to manage people's deaths. Euthanasia, by the way, is derived from the Greek meaning to die well. It doesn't mean anything to do with popping off old people when they're getting a bit smelly or scruffy, you know. And so we would work out the scheme, how we would manage people dying at home to try and keep them pain-free and secondly keep their dignity. And in our way we did. Unfortunately Miss Lyons after a few years went and died from a massive heart attack. And so we then had to look out for another nurse, and who should be surprised that the junior nurse, the SEN, they used to have state-enrolled nurses in those days, a girl called Carol, was a super girl, said, well, why don't Mrs. Margaret Lang up from Cranford would like to come. Oh, right, well, we know Mrs. Lang from when she was Nurse McNamara. So we asked Mrs. Lane if she would like to come and work. Oh, yes, she would come indeed. And she then worked with me for about the next 25 years. Again, another Catholic and Irish who had views on how we should manage this. And between us, we would indeed plan people's time their deaths with us, if you would like, that way, because it's a very important thing to do. It's got quite a lot of prominence these days since the hospice movement from Cecily Saunders and so forth. I learned quite a lot from reading what she'd written about management of pain particularly. But it was a very important part of our work. And then of course they decided they wanted to attach midwives to the practice because we were doing a lot of maternity. And so yes, they would attach the midwives, and so we said, oh fine, we'd like Miss Patton and Miss Rubin please, if you don't mind, because we'd worked with them quite a lot. Miss Patton came from Northern Ireland, and Miss Rubin was the most unusual lady who'd been grilled, who'd been interrogated and occupied France by the Gestapo, and also by the resistance, and she said that there wasn't a lot of difference between the two. Her time of starvation under the Nazis must have been quite horrific. Yes, but this was really a very tough cookie, who at the end of the war, of course, was no longer required on the farm, and her brothers threw her out, and she read that they were looking for nurses in Bedford. She came to Bedford speaking no English, and enrolled and successfully worked as a midwife and a very, very competent district nurse indeed. A lot of regard for Miss Rubin. A lot of regard for Miss Patton, who still lives around here in Springfield Avenue actually. But so we had a very fine pair of midwives who we got on with very well, and with whom we could continue our obstetric practice and deliver more twins and do more forceps. I would be using my obstetric forceps, for example, I would think about every couple of months in general practice, which would be absolutely unheard of now. And we would be regularly giving still general anaesthesia in general practice in the home, and we had an anaesthetic machine at the surgery as well. We used to have an old dental machine, but that wasn't really good enough, so we invested in a Boyle's machine so we could proper decent anaesthesia in the surgery operating theatre for doing, again, minor stuff that didn't require a bed, really. So we were very fortunate in this because, as I say, in choosing our own nurses, of course Miss Lamberg, who was the director of midwives, just happened to be a patient of mine as well. So it all worked very nicely. Miss Frost's assistant, Miss Peck, was also a patient of mine. So we were able to, because we were first on the list to put these people into general practice as working with doctors, specific practice doctors, we were in a very nice position to get what we wanted. And it worked very well over the years. We were then approached by a health visitor. We were always a bit iffy about health visitors. I don't quite know why. Perhaps we never understood quite where they fitted in. But a wonderful lady called Mrs. Holder came along. She was a very senior health visitor, and she said she'd like to come and work with us. And the partners were a bit dubious. No, we want health visitors walking in here, you know. Well, what are they going to do? And she said, yes, there will be quite a lot to do. I could see to it, for example, that all the inoculations were done in the surgery here. And then she said the magic words again, I could do all those, and you would be paid. Oh, I can see my partner's face is perking up. Well, yes, that would be, what a good idea. Well, we'll see how we get on, we said. Yes, that would be fine. So Mrs. Holder came in, and this woman was absolute magic. She got the whole thing, a wonderful system working, and we then found, of course, that we were going to have to do, came easy, of course, the ladies would come for their 6 weeks postnatal, and we would therefore do the 6 weeks baby examinations as well. And I had to read up so that we didn't miss any bits, so we had a proper scheme of examining babies at 6 weeks, having had a proper scheme for examining at birth, because that's the other thing we used to, I felt very important to do. Even if the woman had the baby in hospital, I still like to say, well, I'm examining the baby now here, so I know what I'm looking at here. I'm finding, you know, that I am happy as well. part of the fact it was also good practice. The more babies you examine, the better you get at it, and the better you get at spotting anything wrong too. So Mrs. Holder made a huge impression. We were doing very, very nicely with the baby examinations and with all these inoculations. They were doing fine, because if somebody wanted to see us when they came in for inoculation, quite easy. We weren't go and make an appointment. Right, we'll come out and see you now. Yeah, if you're a bit obliging, you can get a lot more done that way, I always found. But of course, Mrs. Holder then, after a few years, retires. Mrs. Skeet, she's only just qualified. That's fine. I know Mrs. Skeet, she's a patient of mine, and she can come here and we will develop our systems together, and our strengths and weaknesses will complement each other. And that worked exceedingly well. She was great. We kept on doing our postnatal and infant surveillance program. I found also she was very good at spotting deafness in young kids. So I was able to invest some money we got left in an audiometer. It's a nice bit of kit that she was very good at using. So we screened all babies very young, at 6 weeks or so, for deafness. And then again at 6 months. Basically, I learned it because I found that we were going into a stage where more and more interference and control was coming from outside. And I wasn't frankly used to being told what to do, because I reckon I knew it all. Well, well, actually general practice, very humbling discipline, believe it or not. I mean, if you think you're getting clever, something ghastly will happen and you'll be brought right down to size in no time at all, some hideous mistake you make, because it's a very difficult discipline ever to get perfectly right. You can't, because basically you're seeing a lot of people with nondescript symptoms, which may be the harbinger a very, very serious disease, or it may be a self-limiting condition which will get better if you can buy a bit of time. So I became unhappy when people were starting to talk about measuring this and that, and I was going to be told what drugs to supply and what I could do and couldn't do. So then I was going to say I did it on the back of an envelope. I didn't. I worked out my pension. Right, stop now.